Well, I think it's time to call our April BPAC council meeting to order. And I believe, what did I just do with those? One moment, please, while I pull up.
Judith, would you mind please just dropping the agenda in the chat for folks?
Absolutely. One moment, please.
Okay, I believe I have the most. What's happening with my Zoom here? There we go. I believe I have the most updated attendance sheet here. So we will get roll call going now. Welcome, everybody. Aaron Black. Natalie Brown.
Just waved. She's here.
Great, thank you. Savannah Brown.
Present.
Thank you. Charles Davis. Charles today. Okay. Carrie Eckert.
Present.
Thank you. Jacob Fry. I see you, but I couldn't hear you.
Here.
Jacob's here.
Yeah.
Sean Gartrell.
Present. Good morning, everybody.
Good morning. Kelly George.
Good morning.
Good morning. Excuse me. Laureen Gilroy. Marjorie Grimsley.
Here.
Morning. Jenny Guencheva.
Good morning, I'm here.
Good morning. Danielle House.
I'm here. Good morning.
Good morning. Stephanie Johnson. Megan Lovelace.
Present.
Candace Ludwig. Amy Leiden. Dr. Asia Lyons.
Here. Good morning.
Good morning. Sharon Mock.
Good morning.
Good morning. Michael Miller.
I'm here. Good morning.
Good morning. Dr. Camille Sinclair. Dennis Streeter.
Here I am.
Angie Wold. And Annette Zacharias.
Present. Good morning.
Thank you. Good morning. We will let our fabulous BHA members, that our team that is here today, to introduce themselves, please.
Hope.
Yes.
This is Laureen Gilroy. I'm sorry I'm late.
Thank you, Laureen. Appreciate that. Good morning.
Thanks. Hi.
Thanks.
Good morning, everyone. My name is Judith Tieku. I am off camera today because I'm a little bit under the weather. I am sitting in for Caitlin today. I am the engagement manager for BHA and oversee our regional engagement specialist. Thank you. Calendar?
Good morning, everyone. Kalandra Lindstadt. I am the Northeastern Regional Engagement Specialist and the statewide agricultural liaison. I will be sitting in as the Behavioral Health Administration, and I will be off camera because I am taking notes fast and furiously over here. Thank you.
Hey everybody, Aaliyah Andrews. I am the Recovery Services Manager and your recovery TA for this meeting.
Morning, BPAC. Ryan Templeton, Legislative and Governmental Affairs Division Director with the Behavioral Health Administration. So, yep, here with whatever you need for today as Megan Shelton's going to be out today. So I'll do my best to serve as liaison between BHA and BPAC.
Hope we see Charles in the chat joined. So he's present here.
Thank you for that, Megan.
Welcome to our other state partners. And Anne, we're so happy to see you on this call today, Anne.
Good morning. I'm Ann Denton. I'm your SAMHSA funded Planning Council Technical Assistance Provider. Nice to see all of you.
Really happy you're here, Anne. Thank you.
Yes, good morning. This is Bonnie Holiday from CDPHE, and hope I have to say you win the Best Nail Color of April award. They are absolutely gorgeous. And Anne, always happy to see you, especially thinking about any of your colleagues that have been impacted recently.
Absolutely. Okay.
Hope and Megan, would you like me to share the minutes? On the
Sure.
screen? Okay.
Sure. Since our next agenda and business is to approve our March 6th meeting minutes. Does anyone have any feedback, corrections, updates to the minutes? Get those pulled up here. Thank you, Judith. Yes.
I had a question. So it looks like in our minutes there are a couple yellow highlighted items. I wasn't sure what those were.
I am seeing that now. I think these are just thoughts that were not, I think Caitlin wasn't able to complete that. She did reach out to me this morning. I think I'll just reach back out and then ask her to complete that. I missed that meeting, so I can't recall what that discussion was. One moment, please. Thanks for that catch.
There's another one just a little bit further down, and it was a name. I think it was Charles Davis's name that, that I thought, was she not sure that that was Charles that was speaking or?
Right. Okay. One moment.
Okay. Thank you.
Great questions. Thank you for the call out.
Are we are we going to pause on approving the minutes with those questions? If there are no answers, what's the pleasure of the group?
I think I'll be able to just get verification of that name and then just get that sentence completed. But
and then once those are done, I reviewed the minutes and I move to accept the minutes.
Second.
Okay. Well, then our March 6th meeting minutes are approved. And we'll circle back with the information on those highlights. Thank you. very much for that. All right. So last month we had a wonderful block grant funding presentation from Kasha. And we have some space here on our agenda to talk through, discuss any thoughts, feedback, any percolating questions that may have come since our last presentation and our last council meeting, to provide some space to do that here.
The link to that's also in the chat if you want to pull that up.
Thank you.
I'll just say that I thought reviewing them after the fact made it was great for a reminder of things, but also as we know that the political environment has changed a lot in the past couple months. I thought that our the oversight and review and all the stuff and the reporting, I thought it is really good to have this level of transparency. And I thought, oh, okay, this is really good to have, just so that if there are questions from anybody outside who doesn't understand how this works, I thought it was a really good synopsis of the whole thing. And I serve on a couple other funding boards, and I thought, oh yeah, this is really well presented here, because sometimes it's hard to talk about all the different levels of and steps that go through all of this.
And this is Megan. I'll just reflect back with the group, as we always do, that we would love to see a little bit more tracking around that, the funding pieces specific to those demographics and outcomes as we move forward with the guidance of Anne, of course, something to continue to think about as we move this grant cycle forward.
I think if you have any questions for the presenters, that would be great. I can capture those questions as you share them, and then we can get responses. Kayla.
I think the questions for the block grant committee going forward, one, that we're operating in an unstable environment. There's lots going on, but leaving that aside, the sort of the next tasks for the block grant committee are to look at this information again, think through the questions that they had last year, see if any of those questions remain unanswered, and then work within the committee to make recommendations for any changes to priorities that the block grant committee wants to recommend, then for consideration to the full council. And that's how the process should work. And then ultimately, when the block grant is released by SAMHSA, and y'all are working on that, the staff are working on that, involving the block grant committee as questions come up it would be a good practice. And then at the end of the day, part of the submission is a letter from the planning council regarding block grant submission. So that's kind of where we are in the process.
Megan.
Thank you. And I will just raise, if you have not had the opportunity to attend that block grant committee, I know we're all really busy, but certainly we invite you into that space, as that is a bulk of this work currently. And I will reflect back that during the last couple committees, we really focused on harm reduction. And I invite a more robust conversation for the committee as a whole to think through that piece and what other pieces we might want to bring to the table, and reflect that harm reduction may not be available throughout the state. But I do want to encourage people to be curious about that work. And for those of us on the council who are participating in that work, to share how that work lives in community. And I invite us to maybe broaden our scope beyond harm reduction as we look to be comprehensive in our research and analysis in the Block Grant Committee. So it's a party, and I invite all of you to come to it.
Megan, remind us all, when is this party? When is the date and time of this subcommittee meeting?
I will check it out on my calendar right now, or if someone from the BHA has that information, and then I will drop that into the chat for you all. And remember, in between those committee meetings, we're having dialogue over email, or you know, we can chat with folks. So if you are curious about that particular work, we encourage you to get involved, and I'll drop that date into the chat.
Thank you. And Anne, thank you for that helpful information of trying to continue to connect these dots and utilizing what we have through this presentation and this information, and how we're integrating that into the block grant work that we're doing as a council. So that's helpful, very helpful. Thank you. Okay, I see in the chat 9 to 10 on the second Wednesday of the month. Thank you, Kelly. The next meeting is on April 9th, 9 to 10. That's where the party's happening.
That's where the party's happening. And remember that harm reduction is very nuanced, and it is a very specific service, and it's very meaningful for our community, although it reaches a very specific demographic. So I encourage us to broaden our scope of demographic as we continue to dive in. I invite anyone in the harm reduction community to speak to that work, or maybe some people don't even know what is harm reduction, right? If you live and work in that world, you do, but some folks may not. So invite that conversation.
I was just going to add, if there's any other questions, insights around the block grant funding presentation, or that kind of remain or linger after this meeting, please reach out and we'll get those questions answered.
Absolutely. Thank you.
One more time, Joel, I just want to make sure you know that we need consensus to move forward with what we're focusing on with the block grant. So I just hope that we do have that consensus. I'm sorry, Hope, I interrupted, but
no,
I'm not sure we do. And we don't really have harm reduction folks on this call currently. It doesn't appear. But perhaps we bring a vote to the group, Hope, as a way to make sure we have consensus around working on harm reduction as the main goal for this work with block grants.
Well, Megan, I think that when, you know, in the support documents and the reports and everything, you can see that the top 4 priorities are about substance use in different populations and severe mental illness. So I think harm reduction is one of the focus areas, right? But I think that it is the evidence-based intervention that is widely accepted across the country for substance use interventions. So are you looking for consensus for us to support that as a strategy for substance use intervention and recovery?
No, it was just the topic of discussion for
Okay,
the Block
okay.
Grant Subcommittee. It was the sole topic of discussion for Block Grant Subcommittee, which is why I invite more of our council into this space so that we have more of a variety of voices. Harm reduction is amazing, right? That keeps the people we love on the planet. And it's such a important part of the work. I wonder how it may address some of the other pieces that are our responsibilities. Does that make sense, or does it sound like
Well, I think for me, like I run a homeless shelter. So for me, harm reduction is tied directly to substance use. And it is an amazing intervention. Like it's incredible. And but I think one of the other priority areas is as well is severe mental illness. So I'm gonna just come to the committee meeting. And I'm just going to share in the conversation because I think that, there aren't many harm reduction strategies. I don't know that of any harm reduction strategies for severe mental illness. So I'm just going to come to the committee. I think that this is going to be great.
Thank you.
Thank you. That's what I'm finding because that's part of the was my job for this next meeting was to look for harm reduction strategies for severe mental illness. And I find them occasionally listed in the headline, but when it comes down to actually naming things, I've yet to find any.
Megan and Hope, there's a comment in the chat. I wonder, Anne, if you have any response for that. Are block grant funds at risk at the federal level? Can the definition of harm reduction also be looked at through a more mental health or SED lens? And just added a response in the chat. Harm reduction is a good example of how the BG committee can interact with department on an issue. Questions might include to what extent are the funded health plans under MH guided to include harm reduction approaches in their recovery services? Similar questions for SABG. Thank you for your response, Anne.
Ryan, did you want to speak at all to the federal question that Marjorie asked? Are block grant funds at risk at the federal level, or Anne, or someone who maybe has more knowledge in that space?
So Ryan Templeton, Legislative and Governmental Affairs with BHA. So with the federal funds, I think Anne said it very eloquently there, is that we are in uncertain times, right? So part of what we're doing is really going day by day. I'm incredibly optimistic seeing Anne's face today, as Anne's one of those folks who's like, oh wait, can we still reach out to Anne? Because of things happening day by day, which is to me a fantastic sign for us as the state of Colorado and us as BHPAC. With block grants specifically, we have not heard anything about the ongoing funding of block grants being impacted. We at BHA are prepared to address that if it does happen. We have not heard that happening yet. We have had other things that have happened that sound like block grant, but is not the ongoing funding of block grant. We, on March 24th, got 4 notices from SAMHSA about the termination of 4 grants. They are the mental health block grant stimulus direct to agency grant. It's the mental health block grant COVID testing mitigation, the substance use prevention, treatment, and recovery block grant stimulus, as well as the substance use block grant COVID testing and mitigation. We got a notice to terminate those 4 grants. What that meant is that impacted about $24 million of encumbered things. So roughly 60 grantees or contracts were impacted by those 4 grant programs. Those grant programs, we expected those to be done in September. So this is a 6-month earlier than expected termination. So what we did is we reached out to all the grantees. We had them have a stop order. Essentially, they can't bill against that contract any longer. And what we do with all of these and all of these orders that we get from the federal government is we send them directly to our legal, the Attorney General's office, to help advise us, get clarification from the federal government related to, okay, you said this in this in this executive order, but it's a slightly different language than this. And we are also meeting a couple times a week with our other state agents or other states in the letters that they're receiving, which we are understanding that letters are slightly different across states as well. So trying to get how other states are also responding in kind of that larger role of, hey, is there legal recourse that we want to take as a state? We want to jump on lawsuits with other states. And so that's part of the process that we're also going through with each one of these executive orders. So really that is the piece, is that it is really day by day, hour by hour with what we're getting from the federal government. And if you were watching the news yesterday about tariffs, I think that's a prime example of kind of get caught off guard at times related to what's going on with kind of large things happening with the federal government.
Just a question in the chat, Ryan, for you to maybe list those, name the block grants again that were terminated from Dr. Lyons. If maybe you could name those in the chat so we have them. Thanks.
Yep, I'll put those 4 in the chat right here.
Thank you, Ryan. And I know we're going to come back to you here shortly. I want to get Dennis, I see your hand up.
Yeah, again, a kind of an FYI. I've been elected chair of the systems committee, and our first agenda item was on harm reduction. And we got a considerable education from Erin Black in what she's dealing with up north as a council person and the pushback they're getting. First of all, for everyone here, the term harm reduction is taken on a whole different, very expanded meaning due to the divide and conquer approach that DC is trying to burn the country down with, in my view. Anyhow, she has been good enough to forward some recommended interviews for my podcast to again demonstrate the different issues that harm reduction and approaches that harm reduction is taking. In 2 weeks, I'm going to be interviewing the Rocky Mountain Equality on LGBTQ plus community on harm reduction for that particular community. And I think that's going to be important. And I have others in the mill. And again, I'm going to be talking about this in a little bit. I'm one of the agenda items. So again, what you knew in the past, what harm reduction was, is really taking on a new meaning, and it is expanding. And in the systems subcommittee, we are taking that on as our first priority, just so everybody's aware. Thank you.
Thanks, Dennis. I also noticed there was a question around the acronyms that were mentioned above, and I have a feeling, I don't want to assume where that's coming from. I maybe it was Anne in Anne's chat. So maybe the SABG. I don't know if, let's see where it
I'm
is.
not even sure that's right. I mean, I was trying to say the substance abuse block grant.
Ah,
Yeah.
and Savannah, I just wanted to give some space for you to, if there's any other acronyms. And yes, there are so many, and we need to be as mindful as possible that not all of us know what they are, and they as we continue to move that.
Yeah,
Sorry.
yes, thank you for that, Hope. I really do want to know, I'm not familiar with a lot of the technical phrasing, so that's why I ask. And I can look it up if there's somewhere you can refer me to. I'll look it up if it'll save time.
We'll just all be working collectively towards dropping those acronym actual names into the chat as we're doing this. So we have lots of BHA support on this call that will assist with that. And we will try our best to not continue to use alphabet soup in this meeting. Apology.
Ryan.
Thank you, Savannah. Fantastic call out. And I tend to do that a lot. I tend to speak really fast. So be like, hey, slow down, Ryan. Or can you explain that? Like, do that for me. I want to make sure that this is a conversation, and the things that I bring up also have an opportunity to have some discussion back and forth. So if you just need clarification, do not hesitate to just flat out interrupt me as well. As I want to make sure that any of the information that I can provide for
Thank
you
you.
is getting there. Yep.
Yeah, it's important that we all know and understand all the components of what we're talking about here. So thank you for bringing that up, Savannah, so we can continue to make sure that occurs in our meeting. So thank you.
Hope and Megan, it feels like we are actually kind of in the, our next agenda item, the BHPAC business. So I think we can just keep going with those.
Absolutely. We will turn it over to BHA for the SAMHSA grants and state budget updates, please.
I think, Ryan, you've already kind of shared a little bit about the budget shifts and changes. And so maybe if you could please reiterate the status of a state budget and grant, that would be awesome.
If I may, I'll just answer
Okay.
Dr. Lyons, your question live related to the estimated folks impacted by the block grants being cut early. I put in those 4 grants that the names of those, which maybe looks a little confusing as well with the numbers in there. Those again are the stimulus direct to agency. So this is not the funds that were assigned to the mental and behavioral health cash fund in the 2022 legislative session. That the bills in 2022, like the grant program from Senate Bill 22-196 and the grant programs from 1281 and the care coordination ARPA dollars from Senate Bill 177 or the workforce dollars from Senate Bill 181, those have not been impacted. So just to reiterate, all of the other programs that have went out to community, and there's a lot of those are still out there. They are still working on those with those grant dollars, and that was $294 million worth of grant dollars coming out BHA's doors of the larger $550 million pot of dollars for those dollars. This is the direct to agency. So direct to agency being SAMHSA, direct to agency being BHA. It was those COVID specific grants. So what we heard as part of the termination of those grants was the President Biden said the pandemic is over. So therefore these can just go away. So as part of the question, Dr. Lyons, that you presented, it covers roughly 60 grantees, and we are currently getting impact statements from every one of those 60 grantees with the potential to set up where do we go from here based off of what we get from the impact statements. That could drive some, how do we address the impact on a different level or a different funding stream if they're, which we'll talk about the other side of Colorado's funding issue in a second here, or how does that support do we go down a legal side of things with those impact statements as kind of a driver between, or how is this impacting the people of Colorado with a a sooner than expected termination. So those are the pieces that we're going through right now. And then from the other side, the state budget, the long bill has been presented. It was introduced into the Senate chamber. So Senator Bridges is the chair of the Joint Budget Committee. Those are the six arguably most powerful legislators of the 100 at the Capitol, which they presented a balanced budget to the Senate. So it's Senate Bill 25206, and then there's 62 accompanying called orbital bills. So orbital bills are bills that change specific programs or repeal specific programs in order to get to that balanced budget. What JBC had to work with is they had to cut roughly $1.2 billion in our larger across all state departments, all programs. So essentially every single state agency, every single state department went through cuts because of our state's budget issues. So different than the federal budget issues. So what we got from Joint Budget Committee is they were very, very aware of the stuff that is happening, and BHA receives roughly 36% of our funding at the Behavioral Health Administration through federal dollars. So they did not cut BHA funding as deep as other state agencies, knowing that a large portion of dollars for services to people in the name of behavioral health come from federal dollars. So we are extremely optimistic of where we ended up, at least with the introduced version of the long bill. What sort of clarifications can I provide from that, as that was a whole ton of information?
Yeah, it was, but I think that I appreciate that you are collecting impact statements. I think that was kind of what I was concerned about. It was like, the impact on the communities, and how would you know that? And knowing that you're working right now to collect those impact statements to then ask the question of what's next. That's the information I wanted to know. And so I appreciate that you all are doing that. Thank you.
Yeah, I appreciate that. So then the next step, so as of yesterday, there was 61 amendments to the long bill. So whether the long bill package, will say, like those 62 orbital bills plus the long bill, which is Senate Bill 25206. So those 63 bills make up the long bill package, is what got introduced in the Senate on Monday. So yesterday there was a bunch of amendments. There were 61 amendments that were presented. Some of those were approved. Oftentimes those will go eventually to conference committee after the bill passes through the Senate for this week and is likely to be introduced in the House on Monday for them to go through the same thing of, hey, what sort of amendments do we have? Since there was 61 amendments in the Senate, we are thinking there could be up to 80, 100 amendments to the long bill in the House. So then what ends up happening is after it gets through the House, then it goes to a conference committee where they kind of duke it out about what sort of amendments happen, or do we just nix the amendments to get back to the original balanced budget, or both House and Senate agree that we like this, and so then we balance it out that way, and then the long bill eventually gets sent to the governor once the House and the Senate agree to move it forward. So that's really 2 weeks from now. We should have a finished budget that then kind of kicks off the rest of the session that ends in early May. The initial set aside was about $7.5 million for special bills, which is not a whole lot of money for the 100 legislators to duke it out over. With that, is $7.5 million is not a large number in the context of billions upon billions of dollars within the state budget there. So Yep, this is long bill time. So this week, next week, and the majority of the week after that, and then we kind of get towards the end of session and see the rest of the mills move forward. And while I have the floor here, I want to shout out to your co-chair Megan Lovelace, who was supposed to go through a Senate confirmation for her appointment to the State Board of Human Services, which that was scheduled for today, but then got delayed for a couple more weeks, as I think long bill kind of takes precedence over the Senate appointment. So congratulations, Megan, and wish you all the luck to get through that Senate confirmation.
Nobody is allowed to whip against me because I'm so super awesome. And thank you, Ryan, for that shout out. And I did drop if you guys want to listen to the budget conversation, you can listen in. I dropped the link in the chat. You don't get to see the looks on everyone's faces, but you do get to hear the conversations. So you don't have to be at the Capitol to listen to that budget discussion. And you'll have a better understanding then of why some of those bills that were supposed to be in committee this week didn't. They got pushed to next week or the week after, because when they're doing the budget discussion, they don't usually hold committee. Does that make sense, Ryan? Did I say that right?
Definitely. Thank you, Megan.
Ryan, I was going to chat to you, but Anne was asking about the bill number. You had shared a bill number. I think I missed that too.
Yep, I will put the bill page into the link here. I was referencing Senate Bill 25206, which I'll put that in.
Thank you.
I think I put the wrong one in there, guys. Sorry.
Yep, so that's the 2025-26 long appropriations bill. So if you want to dive into where BHA's the funding is, I think you've probably heard me talk about BHA has like 30 odd line items. If you go underneath the operating agency budgets and go to human services, we are page 5 underneath that, and you can see every single one of BHA's funding lines and how much dollars is in each one of those funding lines, which is I often hold this book up in the camera and say, I carry around Title 27. I also include the operating budget as part of my thing, as this is hey, BHA, we have a whole lot of different programs with individual lines, which makes it incredibly confusing at times for providers and individuals seeking or needing services, because they fall into a boutique program that isn't a necessarily coordinated larger system, which that creates providers with a whole bunch of different grant or different funding streams from the same state agency, which I think is a larger approach to try to get to a streamlined version of that. And one of the huge things I'm optimistic about coming out of the Joint Budget Committee was we have been asked to provide a request for information about how we could potentially go down the path of consolidating those line items to make more flexibility for what service delivery and the funding for services actually looks like. Would be a massive, massive win for BHA and the people of Colorado, as then it wouldn't be this specific program has this $50,000 grant that we can't do anything outside of the $50,000 for that grant. We can't give more money to that from a different line because it's $50,000 specific for that grant, which limits the flexibility of how people actually need or receive services. So be on the lookout for that over the next couple months as we engage back with BPAC related to what that request for information may entail as well. So that's us looking towards the already 2026 legislative session before the 2025 legislative session is even done. So.
And if I might add just a note towards what our next budget might look like in regards to some Medicaid cuts, which will make the work of the BHA even more, like, it's already important, right? But the fact that if if those funds can be released in a different way, it's so important that the BHA can do the work that will be dropped off as we see people dropped off of Medicaid if there are substantial funding cuts from state and federal for our next budget cycle. So however we can support the BHA in making sure that those dollars have the most freedom to move so we can reach the most people.
Megan, I appreciate you saying that. And I would also bring that back to the collective expertise on advisory councils exactly like this are such an important piece to coming up with how does the state of Colorado manage through not only our state budget, but also the impacts that we potentially could see from additional things happening federally. I think it is incredibly important that this group really keeps that vision on that it is still people and it's still the people that need services no matter what happens with a funding aspect, and how do we make sure that there is access to quality behavioral health services, whether the funding is there or the funding looks a little bit different. It's still making sure that we are focused on the service delivery and system that impacts the people of Colorado across the board.
No pressure, you guys. No pressure.
Hope I didn't scare anyone away there, but I think that's also the exciting piece to this is that, yeah, it's uncertain times, but also there's tons of opportunity in Colorado as the behavioral health continues to be focused across both parties. And so I think there's optimism even in, or at least there's some silver lining to maybe some uncertain times. So
thank you for that, Ryan. And I can, we collectively here can all kind of come together to understand how challenging this is to navigate these times and what that means for all of you at the BHA. And then I want to reflect, I hear optimism from you, Ryan. And so I'd like to, since there hasn't been a statement coming from the BHA, there isn't like this kind of communication or information been shared yet, and things are moving quickly and changing, and understand that. I guess, is there with this optimism you're sharing, is there anything like you can bring to this council for any more information, or that we could then bring to our communities so that we can share in this optimism that I'm hearing, and just anything from leadership to kind of, I don't know, continue that so we can have more information.
I appreciate that, Hope. Moving to the next bullet on the BPAC business, the boards and commissions transition, I think is that opportunity. I think it's Caitlin has been temporarily reassigned to a BHA rules team, right? So she is still the boards and commissions coordinator, but she is fully moved to the rules team. So, in a temporary reassignment. So it's not a full, like, hey, you are now doing this thing. It's underneath quality and standards. So Tom Miller's how we regulate providers directly. And I think that is the next step of how is the system within Colorado being implemented? We've talked a little bit here about BHA has 3 separate rule volumes. We predominantly focus on provider rules, right? Like, if you're a behavioral health entity, thou shall follow these rules if you want to be endorsed as to provide this level of treatment services, or a different licensing structure if you want to become a recovery support service organization. There's a licensing structure for that, and then you have the ability to bill Medicaid based on providing peer-based services that isn't in a traditional treatment provider that can also bill Medicaid for peer services. So that's a whole rule volume that's hundreds of pages long. We also have 2 other rule volumes that this is what Caitlin and another person from my team, Shane Oram, which many of you know as well, he's also been temporarily reassigned to the rules team, as we need to, at BHA, put a ton of focus in how we are at BHA leading the delivery of what has statutorily been assigned to BHA to do, right? Set that. What does network adequacy look like? What does our full continuum of service delivery look like? So when we talk about other rule volumes, system rules that say The proposal is to say, hey, these are the services that we're talking about. This is what our behavioral health administrative service organizations will be implementing on behalf of the Behavioral Health Administration. This is how we get into commercial insurance networks saying, BHA has been assigned the task of setting up what a behavioral health network in Colorado needs to be. And everyone else across state agencies needs to follow what that vision is and what that direction is. We are saying that that direction and vision should be written down and formalized in a process that goes through a full stakeholder engagement process that is rules. So you absolutely will see Caitlin again in just a little bit different capacity, presenting rules to BPAC, saying, hey, we're thinking of doing this. Do you agree, disagree? Let's do this before we bring it to Megan Lovelace on State Board of Human Services, that then will vote to adopt those rules, which that will be Megan's new role. So that's that process, which that's what I'm incredibly optimistic about, is that BHA is now at a time that we are executing on what BHA was assigned to do. I think there was a time when BHA was created that we celebrated BHA was created. Now we're at the time saying BHA was assigned to do all these things. Now we're doing all of these things. Yeah, maybe 3 years later, but we're there now. That's really more of my optimism, is that that's how we execute and establish a infrastructure that when we get the hills and the valleys of funding, we have an ability to identify where can we transition dollars, where can we transition services to make sure that the people still have the services that they need, or at least a set of core services to address immediate crisis and make sure that people have access to the places they need to go to get the ongoing services. So I don't want to present that I'm super optimistic about the state budget or the federal budget. I'm optimistic about where we're at as a state agency in kind of growing up into the BHA that I think people originally thought that it was going to be. That's what I'm incredibly optimistic about.
Ryan, how can people get more involved in the rule process if they want to? I did drop some links in the chat, but what if people want to learn more? What's the way for this group and our networks to learn more about how to be involved in that process?
The newly reassigned and rules team is having a retreat on Monday that will come with a whole engagement plan. They have not started drafting what the regulatory updates were. I've been talking a little bit, and folks at BHA have been talking a little bit about the CCBHC, Certified Community Behavioral Health Clinic, and the planning grant that the state of Colorado through healthcare policy and financing received. BHA, Behavioral Health Administration, us are responsible for setting up a certification process to get to entities need to meet these rule requirements to become a certified community behavioral health clinic in Colorado. That is part of what the rules team will be doing. There'll be a whole community engagement plan associated with those as we begin to outline what those rules will contain. BPAC, all of you, as we travel around the state, getting feedback, again, before they go to State Board of Human Services and Megan Lovelace directly. Before it goes there, this is the opportunity for advisory councils, for community to weigh in before anything gets adopted, before anything actually formally gets presented, and anything that goes into effect. CCBHC, that Certified Community Behavioral Health Clinics, is going to be on the list. Charlie, last time talked about ASAM, the American Society of Addiction Medicine version 4, and the withdrawal management impact that fourth version of ASAM has created. That drives a whole regulatory update to our current provider rule volume and how withdrawal management is now to be embedded in treatment service delivery, not as a standalone withdrawal management service. So that is an impact on providers directly, but through a regulatory process. So that will also be part of a larger regulatory reform. We're also talking about how do we get to that next level of what does enhanced payment for essentials and comprehensives, and what does it mean for comprehensive safety net providers, that we're also going down this new path of CCBHC. How do those things fit together? Do they not fit together? Are they two very separate things? So those are all of the pieces that we will be coming back here routinely with rules, with the whole outline, and then love some feedback about where we should be and where we should send those teams out to. If you have spots around the state that would like to host some regulatory meetings, we are all open for that as well. Or help us host regulatory meetings, I should say. It's not a, hey, Hope Hi, we come to your neighborhood and you present the BHA rules. No, we won't do that to you, Hope.
Oh, how nice of you. Thank you. This is really helpful to hear this, and I appreciate the clarity and information. I do want to honor, we are a little behind schedule, so I'm going to propose that we take a quick break, get our 5-minute break, do what we need to do. I know this has been a lot of information, and we still have a lot to cover. We come back, we do the presentation with our ta-da team, and then we can circle back. We've got 2 remaining items of business here, but I think just to keep a little bit on track here, this feels like a good place to break. Come back, presentation, and then we'll continue on with our meeting. All right? Sound good? So 5 minutes from now, 10:03. See you back here. Thank you.
And the floor for one moment to reflect on our leadership, and if you are willing to just give any division updates you may have, and maybe honor those who we've lost in this process with HHS. I want to make sure you have the floor for a moment so we can honor the federal work and our connection to it.
And while the recording was happening is when I think you said Anne's name. So I'm not sure if Anne heard that was the call to provide the space for Anne just to share.
If you're comfortable sharing, Anne.
I wonder if Anne is not back yet.
Perhaps we can provide that space again, maybe, Hope, at the end. Okay.
Yes. After our presentation on our fiscal year 24 mental health block grant reporting updates with technology and data division ta-da, I will turn it over to you. Thank you.
Thank you, Hope. Can everyone hear me okay? Okay, perfect. Just wanted to make sure that all my settings were working. Yes, good morning, everyone. Thank you all for having us today. We're going to begin with a quick round of introductions, and then I'm going to provide a brief overview of TDA, the Technology and Data Division at BHA, and what we do as the Data Science and Evaluation team. I'll get us started. My name is Larisha Longworth-Reed, and I am the Evaluation Manager for the BHA. I am pretty new. I started in December 2024, so I am still getting up to speed on BHA's portfolio, but I'm really excited to be diving into the Mental Health Block Grant for this presentation with you today. And I am joined today by my colleague, Matt Worst-Caligari, and I think Matt is back. And I'm going to turn it over to Matt to give an introduction for himself.
Thanks, Larisha. Good morning, everybody. I'm Matt Worst-Caligari, and I'm a data strategist on the Data Science and Evaluation team in TDA, the Technology and Data team. We've had a lot of names, but yeah, Larisha is actually very humble too. She has stepped in and done just an incredible job in a short period of time, and I just wanted to really highlight that. She's done an amazing job. So My role in Block Grant is really I pull some of the queries and things like that directly, but I almost think of it more as conducting like an orchestra of efforts, if you will. It's really a collaborative effort across a lot of teams, and we'll kind of get into some of the details on that. I think you all know Kasha, but many just wonderful colleagues that we get to work with for this larger effort. Back to you, Larisha.
Thanks, Matt. All right, so next slide, please. So the Behavioral Health Administration exists, as you know, to improve access to and quality of affordable behavioral health services in the state of Colorado. And one of the pathways and resources that contributes to this objective is the Mental Health Block Grant. And my team gets to monitor this. And we'll be reviewing in this presentation, when we talk about access here, what that really looks like with mental health block grant is who are we serving, and what does that look like? So by collecting this data and reporting on mental health block grant, our team helps to support that aspect. And we're part of the data science and evaluation team, as we said, within TDA. And next slide. And within the technology and data division, we're really working to ensure that our stakeholders have the information that they need to gather insights and move forward with action. So we're continually seeking to improve our processes, to improve the quality of our data and the insights that we provide. And our aim today really aligns with those efforts. Our intention today is to provide you, the Advisory Council, with information on the Mental Health Block Grant to inform your understanding, inform your insights, and we also hope to gather feedback today from you on how we can continue to ensure that you have the information you need to move forward. So we'll have time for questions at the end of the presentation, and I encourage you to go ahead and drop questions in the chat as we go along, and we can collate those. And then also just know any topics you're curious about so that when we get to the end of the presentation, we can have a robust discussion. And now I will turn it back over to Matt to provide an overview of the Mental Health Block Grants reporting processes.
Great, thanks, Larisha. Okay, so our long-term goal is really to tell a story. It's how can we best tell the story that's reflective of the journey of people throughout the state as they navigate their behavioral health experiences. So, of course, this comes with challenges. There are a lot of disparate systems, data in different locations, duplicated information, things along those lines. But we're striving to make improvements and think about how we can tell the most complete and accurate story in that regard. So as such, we think in terms of whole person health, encompassing all aspects of well-being. But for the purposes of block grant, however, there is kind of a clear delineation of mental health reporting versus substance use reporting. And so today we're going to focus mostly on the mental health side of things, but I just wanted to highlight that distinction as well. Next slide, please. Okay, so the largest singular lift, at least from my role, is the creation of the CLD file. So this is the client level detail file. It's also referred to sometimes as the BCI file, the basic client information file. And this is a sidebar. If you enjoy acronyms, you are going to be pleased with the next few slides, I think. So, but anyway, this combines data from our CCAR data set, which is our Colorado Client Assessment Record, specific to mental health clients, and encounters data, which speaks to the actual services rendered, the treatment rendered, and combining those with similar data from what was the Mental Health Institute, MHI, now referred to as the Office of Civil and Forensic Mental Health, OCFMH, and similar data from them, as I spoke to disparate systems earlier, because essentially taking similar data, similarly formatted, and combining those two, and we'll look in a future slide as to kind of a little bit more what goes on in that process. But it's this continued effort to try to refine and deduplicate that type of information. Next slide, please. So for the purposes of mental health block grant, really all roads lead to URS, so the Uniform Reporting System tables. And these are fairly comprehensive and try to view the data in various ways. And this is at the aggregate level, particularly so this data is shared out via SAMHSA and kind of consolidated compared with other states. But the origination of this is that client specific data that we're referring to. And let's see, oops. Yes, so okay, most of the URS tables, much or at least or most of the URS table data is populated from the CLD file. And then there, I just wanted to highlight that there is additional data that we just enter directly via our own queries and things of that nature, which we'll get into as well. Next slide, please. So how do we gather our mental health block grant data? And so there are a few different ways. And again, this is really a highly collaborative, coordinated effort. As we'll see in some future slides, there are some of the information speaks directly to expenditures. So for example, we have the fiscal team is tasked with completing table data in that regard. And then also the OCF MH team, as I alluded to previously. And so in this process, we have our own internal queries from our data systems, and we perform the outreach and coordinated effort with the OCF MH team to get their similar data. We bring the two files together and perform data processing, essentially analyzing the records side by side, attempting to deduplicate and refine those data. And then we submit that through SAMHSA's DSS portal, Data Submission System portal. And part of that process includes data validation and error correction. Typically, think of things like out of range values or things that are clearly erroneous typo type of information. The portal catches those, and then myself and colleagues of mine refine the data, re-upload, and kind of continue that process until we have a clean submission. And then that clean submission is ultimately transcribed by the team at Hendel into a variety of the URS tables. And then just the note at the bottom is again, that populates many of our tables, but the other ones, that's not the complete list. The other ones we populate and enter directly ourselves. Next slide, please. And the next two slides are really just to show kind of an example of what type of information, what the URS tables really look like. And mostly, I don't want to spend time on the actual numbers here. We have some numbers in later slides, but mostly to just show that the depth and breadth of the CLD file kind of allows a number of perspectives and different ways to view the data. And so different groupings, different ages, again, trying to get back to that, how do we tell that story and how do we kind of see it from as many perspectives as we can? And so the table here we're looking at is table 2A, which is profiles of persons served by age, gender, and race. And next slide, please. This next table is 14C, which is adults with serious mental illness and children with serious emotional disturbance, SED. And you can't see it on the screen, but the age groupings extend to the left and to the right as well. So again, just kind of different ways that we can try to look at the view and look at the data and try to get a more holistic picture of kind of what's going on, the current state of things. Next slide, please. Okay, and so here are just some, I won't read through all of these, but here are some additional groupings of the data that are represented throughout the URS tables. And again, they're grouped essentially to try to analyze the data from various angles for the most comprehensive view about kind of what's going on, if we see deficits, and just to really help drive, are there things that we need to address? What can we take actionable, steps away from this data? And again, just we're on a continuous mission to really think through how we can tell the most accurate and comprehensive story of Coloradans' behavioral health journey. And I will pass it back to Larisha. Thanks, everybody.
Thanks, Matt. All right. Can I get the next slide, please? So what Matt just showed you was a pretty long list of all of the different tables that we report to Mental Health Block Grant. As he indicated, we slice and dice and mince and chop up that data in all different shapes and sizes to get it into the format that SAMHSA requires in these really long Excel spreadsheets with multiple tabs and tables. But for today's presentation, we're really going to just focus on some key areas. So that last list was pretty long, and it included a lot of things about expenditures. We're not going to get into that today, but we're really going to focus the rest of the presentation, on the data that we report to SAMHSA through Mental Health Block Grant that really describes Colorado clients. So we'll be looking at an array of demographics. We'll take a look at the prevalence of SMI and SED, and we'll also look at a view of the data around the evidence-based practices and services and supports that a portion of the clients receive. We're really focused here on replicating that data that is reported to SAMHSA and is requested by SAMHSA, which is mainly descriptive. So today what you're going to see is mainly descriptive information with that significant focus on demographics. And then for that population served, that's really the focus of today. Next slide. Thanks. So we'll really just start with how many people were served by Mental Health Block Grant. So as you can see, for state fiscal year 2023, over 100,000 Coloradans received mental health services that were funded by the Mental Health Block Grant. And of those, approximately 26% were children and youth from birth to 17, and 74% were adults. So that's our starting point of how many people are we talking about, and were they adults, were they children and youth? Next slide, please. And we can take a little closer look at those ages. So we looked at how many were children and youth versus adult, but when we really zoom in and drill down to those age categories, you can see here that the greatest proportion of clients or among adults were ages 25 to 44. And then the greatest proportion of children and youth were in the age range of 13 to 17. So giving us a little more information here about each of these age categories, how many clients were in each of them, and where we kind of see larger proportional representation. When we look at all of those ages combined, so looking at the full sample of 108,509 clients, the largest proportion by sex was female, represented here by over 60,000 clients at approximately 56% of the entire sample. Next slide. We also cut this data up in quite a few places by race, but here we're presenting the race overall for everybody. And by race, the largest proportion of clients served were white, and that was followed by a proportion of clients reporting that they were some other race, as indicated here. I do want to note here that these are the categories designated by SAMHSA, and we are required to adhere to these categories for reporting. But I do want to acknowledge for this group that is a sizable portion of clients represented here that are lumped into this some other race category. And that's definitely highlighting for us an opportunity for greater detail here that we would love to have. And also highlights that we do have some limitations for this particular demographic when it comes to race category. We are limited by what SAMHSA asks us to report here. Next slide, please. So moving a little bit adjacent to the demographics and describing the clients in that way, we also are able to take a look at employment. So as you can see here, approximately 1 in 3 clients reported that they were employed. And then 2/3 of the sample were either unemployed or not in the labor force. Those that were not in the labor force were either retired, had sheltered employment, sheltered workshops, were a homemaker, a student, a volunteer, or reported to be disabled. So that's a pretty large group of individuals all put together here under not in the labor force. Next slide, please. And then when asked to report on the living situation, about 96,000 clients reported that they had a private residence. And so that's called out here. And then separately, we looked at among all other living situations, so those that did not indicate they were in private residence, what was their living situation? And the largest proportion of the sample reported they were unhoused, followed by being in an institutional setting or a residential care setting, and then other, where we have a little bit less detail about the living situation within that other category. Next slide, please. So as I mentioned earlier, we would take a look at the proportion of clients that were indicated as having severe mental illness, SMI, or for children and youth as having severe emotional disturbance, FCD. And so among our 108,000 clients and those that were children and youth, 53.9% were identified with SED, while 70.6% of adults were identified with SMI. And next slide, please. So moving into the services and supports, here we're looking primarily at adults with SMI. So for adults with SMI, we report on a selection of services and supports that clients may receive as part of their services. So as you probably note here from our original population sample of over 100,000, we have a sizable decrease in the numbers that are reported here for each of these services and supports. And we did just want to really highlight kind of what these different services and supports are and what kind of numbers we're seeing reported in each of them, even though they are lower than the overall sample. This could be for a variety of reasons, including the fact that many individuals may be getting services and supports that are just not part of this menu. These, again, are selected services and supports that are required for SAMHSA reporting and do not fully capture all of the services and supports that may be offered to clients. And next slide, please. So we've gone over a lot of the description around the clients and who they are and what their demographics look like. And as we discussed, this is mainly what is reported to SAMHSA for mental health block grant, but a little more information about the client and their self-reported outcomes following receipt of mental health services is intended to be captured by the consumer satisfaction survey that's required for the mental health block grant. And this survey was not completed in the last year, and so we do not have data on that to share with you today. But this survey is really intended to help us answer some of those questions further down the pipeline of not just who is served, but what happens after they receive services. How are they feeling? How are they doing? And the survey answers questions about the consumer's evaluation of their care, including their perceptions of their access, the timeliness of care, and some specific domains that look at social connectedness and functioning for youth. Next slide, please. Just to give you a little more example of what this survey looks like, there are 2 versions of the survey, and one of them is for adults. That is shown on the left here, the Mental Health Statistics Improvement Program Consumer Survey. And there's a version for children and youth that is completed by caregivers, the Youth Services Survey for families. And what you can see here is these items really do, this is just a sample of the survey, which is over 44 items long. But this sample really represents some of those items that get at outcomes of after receiving services. How are both adults and children and youth who receive services feeling? Next slide, please. So as I indicated, this survey was not collected during the previous reporting period. However, the BHA is currently on track to implement the client survey for this year to include all consumers from 2024. To accomplish this, the BHA has selected a vendor for administering this survey beginning this year, and the data science and evaluation team, so my team has been working with the vendor to develop a plan for this survey. And we are planning to start recruitment this month, and then the survey will launch in May, followed by a period of survey feedback. And then we are really excited to be expecting data from clients as early as this fall, which will then be included in subsequent reporting. And now that we have a vendor in place and we are implementing this new process, this should continue year over year so that we can have this really rich data and have a better picture of what clients are experiencing. So this is a really crucial piece in moving us forward from just describing clients to understanding their experience. And we're looking forward to having that data. And next slide. So that concludes our content for the presentation. And now we'll move into Q&A. And I think I heard several chimes in the chat. So I'm hoping that is some lively questions coming through. And I'll just move over to take a look at that now.
Thank you so much, Larisha. I haven't seen any questions come in yet. And so please feel free to unmute or put your questions in the chat. Thank you.
I have a question, and I've been thinking about it, and it might take me a minute to figure out how to ask it, but I really like all the data. I'm overwhelmed by it. I think you guys are doing a good job in that. I'm wondering if there is a follow-through from like last year and the year before for the same person. So let's say I checked in 2 years ago, and now you're looking at me this year. Do you see any trend in my care that is separate from the client reporting? So, you know, I think with anybody, my caretakers, that's not the word I want to use, my counselors, my people have seen me for 3 years, and I was a wreck 3 years ago, and now I'm doing really well. But I'm kind of a depressive, pessimistic person. And when I fill out the survey, I'm thinking, I'm not doing that well. And I don't really like this agency. They should be doing better for me. Is there a way that you are taking into consideration those kind of things, or do you just kind of categorize it like, okay, here's the person's response, and bear in mind it is their opinion, and we've got data to prove that we're actually doing better than they think we are. So I'm wondering about that kind of use for the data that you have.
Yeah, excellent question. So since we haven't I think your question, the first question was around the client survey and linking over time and linking to their other sources of data. So ideally, once we get the client survey, if an individual is then still in our system year over year and they have a unique information to identify them, we would love to link them over time to see what's happening if they continue to receive services. I am going to ask Matt, our data strategist, to speak to the ability to link to their data in our broader data system that's not coming directly through their surveys, but may tell us a little more about their practitioners' view of their outcomes, because I need his expertise on that one.
Yeah, and it's a great question. I think that this highlights an area where the the larger reporting efforts kind of lose that piece of the story because it is kind of it all distills down to the aggregate numbers. And I think that the point you're making is most directly spoken to by those survey results. And one of the approaches that we've taken with the survey is to ensure that each invitation for the survey is individualized so that we can subsequently bind that back to the client record in our data systems. And it's kind of something that we haven't been able to do. As Larisha mentioned, the survey wasn't even facilitated last year. So it's a little bit of new territory, but the long-term goal is exactly what you're describing, where we have the ability to perform that outreach, bind the results back to the client's record, and then theoretically you could have multiple iterations, 2 years, 3 years, and beyond that could still be tied back to that client. So you could start to do some trend analysis or, do we have overall kind of an upward improving trajectory? Is it kind of a mixed bag, or do we have negative kind of a decline and things like that, which again then becomes an actionable piece of information that we hope to be able to use to, then perform additional analysis, but also possibly community outreach or refinement of various programs to try to really resolve, any issues that would come from that data. But again, I do think that that's mostly spoken to by the survey results. So we're really excited that this is happening and that we're going to have really an insight that we haven't had for at least my time here. I've been here for about a year and a half, I guess it is. And so really kind of getting more insight. And I think that you also get when you're speaking directly to the clients through the survey, I think you get sometimes a little bit more of a raw view. You get that raw response of how do you really feel about that treatment and how are you doing things of that nature. So we're excited to dig into that data when we have it. And I think that's a great example of how it can be used. Megan, I see
Excellent.
your hand up. Oh, sorry.
Thanks.
Go ahead.
I don't want to cut off Laureen. Did you have more to say? Okay. Thank you, Laureen, for those comments. And I think it's a great point because sometimes the stories that consumers tell can be different than the stories that providers tell. And it's not like the West Side Story. I really don't want it ever to be where there's this huge rift between our amazing provider community and our amazing client community. We're in unison, right? Because we're all working towards those same goals. What I will point out is that in rural places across Colorado, it's sometimes difficult to find a provider that fits your needs. Sometimes we only have one provider. Sometimes we only have no providers. And it can feel scary if you're a client to be honest in a survey or to give authentic feedback if you might be afraid that you might lose that service, especially if you don't have access to transportation or broadband or other ways to enact with that particular service. It might feel like you might not be able to speak into that space in an authentic way because that service is probably a service you rely on for your life. And so I wonder if you'll think deeply into that as you think about feedback loops and how we bring communities together through our data, not separate them with the data. Thank you.
I see a hand up really quickly, Megan. I wanted to address one of the points there. I think that's an ongoing, specifically the rural accessibility of services is really kind of an ongoing challenge. And I think we've developed additional tools. I want to say OwnPath is the name. My mind's all over the place this morning, but we're trying to develop additional tools and resources to help bridge clients with the most accessible services for them in their specific region and area. But that's a great call out that the rural accessibility of services and it's also is a challenge, and it's also really kind of exacerbated by funding issues that we're all well aware of and things of that nature. So definitely a good call out there, Megan. Thank you.
And Megan, I just also wanted to say one of the things I think I heard was around some potential hesitancy among clients of being honest in a survey because of that risk, because of the limitation of resources where they might be. And I really appreciate that, just because as we work to put a process in place for the survey, we're working with an external vendor, and we have information about the fact that results are confidential, but it just really, to me, speaks to the need to make sure we really establish that clearly in any type of solicitation to provide feedback so that people feel as comfortable as possible. So I really appreciate that. I think Marjorie might be the next person with their hand up.
Yeah, this is Margie Grimsley with the Colorado Federation of Families, but I just wanted to make note. I don't know who the vendor is, but there is the state collaborative management programs, and we have a family voice and choice committee because we have been collecting family feedback through that process. And CSU is the vendor that has been working with us, and amazing work on and time. I know Sharon Bach is here, part of that committee, and we really put a lot of that group. Their evaluation team has really created some amazing documents, videos, how to engage families, how to have them feel comfortable in being willing to give that feedback. And I really emphasize, especially what Megan is saying, because people are very afraid unless they really understand that what they're sharing can be done in a safe world. Confidentiality is hugely important, but just that first steps of engagement are so critically important. So I always hate to have somebody start over when something is already, we have a lot of policies and procedures in place on how to do that well, that others can learn from. And since it is, that's also a state, and we're probably working in some of the same exact counties. So just to highlight that, and maybe you can benefit, or whoever the vendor is can benefit from that work that's already being done. So I don't know, Larissa, if that's something that you're aware of. I can certainly connect you. If you put your email, I don't know if it's in the document, then I can send you that contact information, but it's certainly something to learn from and not have to start from scratch.
Yes, that would be most welcome. And I will put my email in the chat right now. I would love to have that connection for multiple reasons, including this outreach. And
There are
I
a lot
think
of great, yeah,
Oh,
this one, yeah.
might
Sean.
have.
Sean's hand is up, I think, for a question.
Yeah, thank you. I wonder in these, gathering all this data, if there's been an effort to engage with non-clinical service as well, because there's a large amount of folks that never engage in clinical service and engage in the alternatives to the mainstream clinical services like peer support, respite, all of the other options that are out there. And how are we getting the information from those folks about how the services they're receiving are working for them.
Yeah, Sean, I am not certain about the answer to that question, so I may have to go digging to get a little more information. Matt, you may know a little bit more about how our data is coming in. It really is coming in through our licensed providers, and I think some of them may provide those services, and like that list of evidence-based practices and supports provided, it's not that list that we showed wasn't exhaustive, so may not have included those services, even though they may be engaged and included in the sample. But I don't have 100% confidence in that statement, so I do want to ask if Matt has a little more insight. If neither of us does, then we can find out more and provide that information back.
Yeah, Larisha, I also would need to follow up to double check, but I do think that that if it is being captured in this data that we're referring to, it would be through the EBP, the evidence-based practice, essentially the supplemental data for specific other treatments that would be included. And that's largely actually driven or facilitated by one of my colleagues, Jasmine. But I'd need to look into that to be sure what's included in that.
Leah?
Sean, I love this question very, very much. So I just want to let just this whole group and especially Sean know that this has been on the to-do list with Tada and myself for a very long time. We have had to really get the clinical stuff and everything that they were just talking about there first, and then I have meetings with individuals with Tada periodically just to say, hey, we're here, we need to start looking at this data as well. So I just want to let you know that that is happening. And then with the programs that I manage, because of deliverables and kind of the limitations that we have for deliverables, but I get some really great information from a few of the organizations, the recovery community organizations that I work with, or peer services. I get limited information from them, but also the BASOs are going to come, and so when we're working with the BASOs, I think that those of us that work in program at BHA will have a lot more bandwidth, because we're not doing some of the things that the BASOs are going to take over doing the bandwidth to kind of do this stuff ourselves. No offense to that, but so I have some, and I have to say, I work with Colorado Mental Wellness Network, and from Hope, I get outstanding like quarterly reports that have really great things on them, but I only work with two other programs. So anyway, I just wanted to let you all know that it's on the burner, I swear. I'm really looking forward to hopefully working with Tada, and if that's not a possibility, then I'll have some bandwidth once the bosses come on, and maybe we'll even get a committee together to all do it together. So all right, thank you.
Thanks, Lilia. And I don't even think we have formally met. So that's how new I am to Tada, is that we haven't even connected yet. So that's some of our challenges that we're overcoming. But that is just a note for me to reach out to you later. And as you mentioned, like, we do have a lot of other programs that we are either evaluating or hoping to evaluate. They may not be captured in the mental health block grant data that we just discussed, but there might be other sources that maybe at another meeting, if there's specific interest, we could look at talking a little more about those kind of other services and supports, just not specific to what we have to report for mental health block grant because of those requirements and limitations there. So.
Well, thank you so much, Larisha and Matt. As a very grateful mental health block grant recipient and the reports that I'm providing, the data that we're sharing to kind of understand where our recovery support services landing within that as a part of it. And so this is a great question, Sean. I really appreciate you bringing up other non-clinical evidence-based practices that might not be a part of this reporting. So this will be interesting to see how that continues to kind of unfold. So thank you for this information. I also just had a quick question. These client satisfaction surveys, who disseminates those? Like how will clients, who's disseminating those? How will they receive them?
Yeah, so our current vendor is Alterum. They are an evaluation and survey vendor that was selected earlier in the year to do this work. And so they'll be sending out a recruitment information on behalf of the BHA through primarily through mailings, because the information that we have about clients who receive mental health services and their contact information is primarily mailing addresses. And so they'll be sending out letters and follow-up postcards and letters for a couple of iterations to help clients navigate to a website where the survey will be hosted online or could be accessed by mobile devices. And then they'll have an individualized token. So that's what Matt was referring to, of our ability to connect their survey to other information. They'll be able to enter that token and then get into the survey. Does that answer your question in a little more detail about the process?
It does. And knowing that it's not coming from a provider, like these won't be disseminated from a provider, because that would be really awkward and awful. I receive services from you and then you're like, hey, how did I do? And so these are some of the components of just making sure we're clear on that wouldn't work, and some of the issues that have been brought up from rural components of, like Megan shared. And so just wanted to understand who is disseminating the surveys, and also sounds like you're mailing and then taking into consideration through the digital accessibility for those that are unhoused and don't have a mailing address. So that's important to take note too. So thank you, Matt.
Yeah, I just wanted to speak to something that was said a second ago. With regard to BASOS and the rollout there's also additional ongoing work with refining the data model to essentially try to shore up what types of data we get regularly. And specifically, as Larisha was mentioning, we've had to lean on mailing for this survey, but we fully acknowledge that's going to largely or entirely miss the unhoused population, for example. So what can we do there? Like we want to be, and with regard to the survey and the facilitation through Alterum, your point is excellent as well, that, it's important that this isn't from a provider saying, how did I do? We've tried to set up as safe of a space as we can, and kind of decouple those, I guess, in a way. But we are actively trying to refine and improve the data that we get. So, for example, I would love for a future iteration of the survey to just go directly to mobile phone, because we know that most people generally have a mobile phone. Similarly with email, if we have that piece of data, that's by and large 99% of the time, right? It's going to be a unique value. So that's another, we need to be able to lean on unique attributes to even things for like deduplication of records. Having those additional data points helps to ensure we're talking about the same client, or is this a different person if they're both named John Smith or something along those lines. So just wanted to speak to a couple things there as well.
Thank you. That's helpful, and appreciate those components being taken into consideration. And thank you. This has been I don't know how we're almost at the end of our meeting here. This has been a very informative and helpful presentation. I just want to thank you, Matt and Larisha, for all you're doing and for this beautiful presentation you had. And I'm sure we every meeting, as you saw, I don't know if you were here earlier, we have the beginning part of our May meeting will be to come back and ask questions and bring things that come to mind after this presentation. So I have a feeling there'll be some other questions and communication. So thank you so much for all the work that you do and for this beautiful presentation. I wanted to, I know we're running out of time here, but Megan, I wanted to also come back to, we were gonna kind of give Anne some space today.
Yes, I just wanted to recognize we got a little off agenda, and I recognize, Dennis, we haven't given you that space, but we do want to give space to Anne to address directly some of those HHS cuts and just hold space for that conversation, as we know it's all heavy on our hearts. And we'll yield the floor to Anne.
So yeah, I'm happy to talk about what I know. I think that the problem is there's more uncertainty than knowledge in terms of what's going on. We do know that most of the regional offices for SAMHSA were closed as of earlier this week. And I can tell you that there is a lot of activity in terms of taking websites up and down. So this morning, I didn't do it myself, but one of my colleagues said that the block grant website was. It's like reading tea leaves. We have no idea what that means. And I'm not even positive that that's true. Just one of my colleagues had that experience. All equally concerning, I think, are some of the programs that are looking at cuts that are necessary, but maybe peripheral to behavioral health services. And I'm thinking particularly of cuts to housing. So there are, HUD has cut 60,000 emergency housing vouchers out. That program was set to expire anyway, but that's a significant number of vouchers, and that's effective immediately, so that anybody who's on an emergency housing voucher now is looking at not having that support potentially next month. On the other hand, HUD has increased funding in the continuing resolution. They increased funding to the ordinary tenant-based rental assistance programs. And so, again, tea leaves. We're not sure how all that shakes out in the end. We'll see, though. Everybody that I know is keeping an eye on it. The other thing that I think is particularly concerning with regard to the HUD funding is homelessness assistance. And y'all have mentioned people who are unhoused in this meeting. And I think there are lots of problems facing people who are unhoused, access to your system and access to housing. And the homelessness assistance grants, there's been a lot of disruption and a lot of negative things said about the Housing First approach, which incorporates harm reduction, anticipating that also will not be popular. And so we're looking at renewals for continuum of care funding. It looks like there may be a way for HUD to fund those, but any new projects that were approved may or may not come through. We just don't know. But it's very concerning. And I don't think there's any way the states can, no matter how well motivated, I'm not sure that the states can make up for these federal shortfalls. That's all I got. Things are happening, lots of things are happening, and there's a lot of uncertainty.
We're glad you're still with us, Anne. We're so happy to have that connection and your expertise and guidance through all of this. So thank you for that update. And we are we're at public comment time. Dennis, I wonder if we move your update to our next meeting, or if you could update over email so we can yield the floor to our public. And we apologize for getting behind on time. We love your podcast. Public comment? Those members of the public not voting, we want to hear from you.
If I could just jump in real quick, I will send an email out about the podcasts that are posted. Margie Grimsley did a terrific presentation on the SAMHSA's new and improved system of care for children's mental health. I will send that link with the email. And also, we are going to do a follow-up on the class action suit against Colorado that's been settled about the use of funding for the system of care. And Margie is very steeped in that, and she's going to let me know when she's ready to do that. But other information, I'm going to send a blanket email to everybody. The other thing is I think it's terrific that everybody has these questions, but we don't have enough time to really do our agenda. So I'm going to request we discuss lengthening our meetings back to what, not necessarily the 3 hours we used to do, but at least adding some time to our meetings so that we don't stifle questions and comments, because this is really terrific stuff. And I appreciate all you guys being this interested.
Thank you. Thank you, Dennis. Tasha, you had your hand up? No?
I did. I just wanted to say how important housing and these services are for people with mental health, mental health, mental health issues. Because without providing these services, people aren't going to get to where they want to get and live the quality of life that they want to live. And with the federal government and the cuts and everything that's happening, that's going to create more of a crisis. And that's when our mental health, our suicide rates are going to go up, substance use is going to go up, and it's going to counteract everything. So I just encourage everybody to continue to stand up and fight for the people, for everybody, and especially for the people and the children with mental health disorders that need it so they can live the quality of life that they deserve. Thank you.
Thank you, Tasha. Kate.
Hi there. I did put a question in the chat regarding the filling of Rachel Simpson's position as the
Yes.
community engagement specialist out here in the Western region.
Yes, Kate, thank you so much. Because of the our limited time, I had sent a response in the chat, but yes, we are in the process of recruiting for that position. But please do reach out to me or Megan for any questions or concerns, or if there's anything you'd like us to connect on. I'll be
The
happy
other
to
issue
schedule
is, okay,
a
the other
meeting as
issue
well.
really has to do with the fact that, West Springs Hospital closed on March 10th. So as you can imagine, when you have a hospital like that closing, where do people take their loved ones for crisis care? It goes to St. Mary's Hospital in Grand Junction. They could go to the crisis center of Axis Health in Montrose, which doesn't even have beds. They have lounge chairs. They mainly do substance abuse. My son was there, and frankly, it was substandard care. What is the state doing to address these issues? Because it's chaos out here. There is no hospital between Denver and Salt Lake City.
Hope, I know we're at time, and I wonder if we just put that on the agenda, Kate's concern, and we raise that up in because we're at time, but that's a very important thing to discuss. Perhaps we raise that up in the next meeting.
Megan, thank you for that. I have asked questions before, and they never seem to come up on future agendas. So I am concerned about it, and I think we deserve some answers out here in the Western Slope. Okay. It's a severe situation, as you can well imagine. St. Mary's is even writing letters trying to get the state to address these issues. Their ER doctor is overwhelmed. Their facility is overwhelmed. What's the state doing about it?
Ryan, I have to see your hand up.
quick update. I was with the Commissioner of Grand Junction yesterday, meeting with community members, including St. Mary's Hospital, the two other critical access hospitals, as well as Mine Springs, and Public Health and Human Services, as well as some foundations out of Grand Junction to try to get to this specific concern, Kate, that you bring up. So thank you for continuing to bring this up. I think it doesn't ultimately just do its service to put it onto the next agenda item. So Kate, can I reach out to you directly to talk about what the next steps within that community approach that they're going through right now over in Grand Junction?
Absolutely.
Perfect.
Kate and Ryan, would you mind if I inserted myself in that discussion, because I'm also a fellow West Sloper with similar concerns. But Kate, I do not want to take your time with Ryan if you need that.
It's okay. Go ahead.
Perfect. Thank you.
Okay. Well, thank you all for being here. Our April BPAC meeting is now adjourned. Thank you, everyone. Please take good care of yourselves.
Thank
and
you,
each other.
everyone.
Thank you.